Good morning. My name is Martin Dichgans. I'm the president of the European Stroke Organization, and I'm at the 7th ESOC conference, which is held virtually this year. And I'm here with Dr. Mark Bakker, a PhD candidate at the University Medical Center Utrecht, to talk about his work on intracranial aneurysms and the relationship between intracranial aneurysms, genetic risk, and aneurysm location, multiplicity, and age at rupture. Hello, Mark. So, your study made use of large-scale genetic data on intracranial aneurysms. Can you tell me what you were trying to do?
Yes, definitely. Well, first of all, thank you for having me. Really delighted to present at ESOC this year, and happy to have this interview with you. So it actually started more or less last year when we conducted a genetic association study on intracranial aneurysms. So we found a bunch of genetic risk loci that were strongly associated with intracranial aneurysm status. And we were also able to explain quite a bit of the heritability. So we really thought, is there a way to bring this genetic information and these genetic findings to something that we can actually use in the clinic? And there are different ways to do that, of course. And here we chose for a genetic risk score approach. So we use our genetic association data to create a genetic risk score to predict intracranial aneurysm status. And after we did this, we saw that indeed it was associated and predictive of, actually not intracranial aneurysm status, but the age at which a person gets an aneurysmal subarachnoid hemorrhage. And we also wondered whether this had an added value on top of the already known clinical risk factors, which are hypertension, smoking, and female sex, of course. And we did find a small, but an added value of this genetic risk score in prediction of aneurysmal subarachnoid hemorrhage age on top of these clinical risk factors. And then a second thing that we wanted to look at is how this genetic risk relates to, as you mentioned, different aneurysm and patient characteristics, such as age, location of aneurysm size, and so on. And we found a couple of things here. First of all, well, maybe not surprising after what I mentioned first, but people who have a subarachnoid hemorrhage at a younger age, on average, have a higher genetic risk score for intracranial aneurysms. And we also found that there's an effect on location of intracranial aneurysms. So people with an aneurysm at the internal carotid artery had on average a lower genetic risk score compared to people with aneurysms at the other locations. And then finally, there was a nominally significant effect where people with multiple intracranial aneurysms had a slightly higher genetic risk. But I do have to say that these people also more often had hypertension and more often were smokers. So we're not sure how how that actually works.
Well, that's very interesting. From what I understand, your aim was to generate a genetic risk score that integrated multiple genetic variants across the genome, and that would predict intracranial aneurysms. And what you found is that your score modestly improved the prediction of aneurysm hemorrhage, as you indicated, and when added to clinical risk factors, whereas your score did not improve the prediction of the presence of an intracranial aneurysm. How do you explain this observation?
Yeah. That might sound a little bit counterintuitive. So I think there are two different things at play. One is, why don't we find prediction for intracranial aneurysm case control status? And then why do we actually find prediction for the age of subarachnoid hemorrhage? And I think it's important to realize what we also showed in our genetic study last year, that genetically intracranial aneurysm presence and a rupture of intracranial aneurysms are very, very similar. Genetically roughly identical. So it's not so much a surprise that we do find prediction of hemorrhage, but we unfortunately don't find prediction of intracranial aneurysm status. And I think one of the main reasons there is in control populations, intracranial aneurysms are usually not detected. Only when they rupture, we realize people are carrying an intracranial aneurysm. So in terms of statistical power, it's more difficult to predict case control status of intracranial aneurysms.
Well, that makes absolutely sense to me. one question that came into my mind when I was listening to you is, are there any similar scores for aneurysms in other locations, such as the abdominal aortic aneurysms, and what is the experience with these types of scores? Would you expect these scores to be similar to the one that you developed?
Well, as far as I know, I'm not sure if there are actually scores for aneurysms at different locations in the body, like in the aorta. It's quite a developing field, and the largest genetic association studies for those diseases also, like in intracranial aneurysms, recently actually got there in terms of sample sizes, the statistical power to generate this genetic risk score. So I'm sure people are working on it. And I expect, roughly similar things in terms of how well it predicts. And, as what we found here.
Well, that's exciting. So you're really the first one to develop such a score for aneurysm rupture. Can you give us an idea of the data sets you used and also of sample size?
Yeah, sure. So there are kind of three getting Dutch there, three kind of layers of data. First of all is the genetic association data, which we collected from the latest and largest genome-wide association studies for different aneurysm locations, but also related diseases such as other stroke types, hypertension, and so on. And these are usually performed in sample sizes of, if it's a case control status, thousands or even tens of thousands of cases, sometimes hundreds of thousands of controls. So there's a really, really large data sets. We then combine this genetic information and trained our genetic risk score in the UK Biobank. So there are roughly 1,100 intracranial aneurysm cases and about 400,000 controls of European ancestry. And then we finally validated the genetic risk score in the Hunt study from Norway, where there are 800 intracranial aneurysm cases, just over 300 subarachnoid hemorrhages, and I think by heart, roughly 60 or 70,000 controls.
Which means you have genotypes on all these individuals.
That's right. Yes, well, that's right. Yeah. So we don't have access to all of them, of course. Also, a lot of collaborators from the Hunt study, of course, the UK Biobank, and so on. But you're absolutely right. There are genotypes for all these hundreds of thousands of people available. Yeah.
That's very impressive. What do your results mean for clinicians? Is your score ready for implementation in the clinic, and or related to this? Do you envision what do you envision to be the next steps before implementation?
Yeah, so it's kind of a yes and a no. So if we're looking purely at what is possible from a kind of computational perspective, then yes, this can be implemented. So a genetic risk score is nothing more than for many different genetic variants on the genome, a partial genetic risk score. So someone with these scores, which we will of course make available for other researchers, and with a little bit of bioinformatics experience, could calculate a individual level genetic risk score for a patient or a control or a cohort. So that's very feasible and definitely not far away. And I think there are a couple of limitations still before this can kind of widespread be applied in the clinic. I think the first is good to realize that all our genetic association data, our validation and training and so on was performed in people from European ancestry. So we have no idea whether it will be predictive in, for example, people from Japan or people from Africa and so on. So that has to be figured out. And then it's more a recommendation. I think it would be good for any population, even within Europe, to have a sense of what scores are actually really high for a country where we want to apply this, what scores are average or what scores are low, to really see kind of the context of this genetic risk score in terms of prediction of cases, to have a good cost-benefit ratio of applying score. And other than that, I think it's also a matter of trying to see what's happening in the real world. So this was done in a kind of a scientific setting. I think unless we actually try to predict in a prospective cohort, we're still not entirely sure where this genetic risk score will bring us.
Well, that makes sense. We may want to know more about this. Where are we going to be able to read about your study in detail?
Well, so right now we're finalizing a manuscript. So still a couple of collaborators that will also look at it, see if there are any pitfalls, things we forgot. So then we'll also decide where we want to submit it, and then hopefully scientific journal will be happy to publish this. So it will take a little while, and for the genetic risk scores itself, we'll make sure to make it publicly available for researchers to start using it as soon as possible.
Well, fantastic. Thank you very much indeed, Mark. I hope you have a good meeting here, and good luck with your future research. Thank you.
Thank you. You too.